covering the stories that impact your life, your town, your state, and your future. This is the Means Report with your host, Brad Means.
Hello, everybody, and welcome once again to the Means Report. We appreciate you spending part of your day with us as we mark Lung Cancer Awareness Month. All November long, the spotlight is going to be shining on that disease, and for our purposes today, the spotlight shining on research that's being done right here at home and treatment that is being done right here at home. Treatment that's changing the way we approach lung cancer, and it really is a glimpse into the future of medicine as we take a look at the hybrid operating room. And I can't think of a better person to explain what a hybrid OR is and how it benefits patients and physicians than Dr. Karsten Schroeder. He is a thoracic surgeon at the Medical College of Georgia, and he treats a lot of patients, has for a long time in traditional operating room settings, and now you have this hybrid OR. Dr. Schroeder, welcome back to the Means Report.
Thank you for having me.
So it's a one-stop shop, right?
Yes, it's a one-stop shop if everything goes as planned.
Sure.
But the idea is we have lung cancer, and lung cancers start normally without any symptoms. So, you know, we have the free lung cancer screening. We often pick people up with very small cancers or nodules, and then it's tricky to get to them. Sometimes we have anatomical problems to get to the area because they're so small. You cannot, with classical surgery, get to a biopsy or take them out. So the beauty about the hybrid OR is you're in the OR, so where I like to be, but we also have basically a CT scanner in the operation room, so they are combined. And the even more beautiful thing is it's not the classical big tube CT scanner you think about. It's basically a C-arm where we do fluoroscopies. So if you think about vascular procedures, they use this for fluoroscopy and see the vessels with contrast. This one now turns, and with a 3D spin around the patient and a lot of mathematics and computer behind it, you can see a CT scan from this fluoroscopy spin.
And the patient never leaves the table that he or she has been on the whole time.
Whole time. So it's the same anesthesia, same provider, and we go from diagnosing the patient, because let's say we can do a biopsy or a very special bronchoscopy to get to a biopsy. And if we then even mark the tumor, we have little metal markers, we can put them in there. And we can also use that same system then to use what we call an IVATS, image-guided VATS, which is minimal invasive surgery to the chest.
So let me get this straight. I can walk into the room, the hybrid OR, you spot the mass, you biopsy the mass, and you zap it in the same day?
I mean, zapping, it depends what you mean. There's different zaps. I mean,
yeah.
I like the zapping of taking it out as surgery, which gives you basically the best survival.
Yeah.
But yes, we can go from diagnosing it, staging it, and then to the treatment in the same setting, one day.
How long did it used to take from the time that you said, okay, there is something in there? How long does that whole thing play out before treatment, before surgery?
Depends who you see. So let's say you see the PCP, there's a X-ray that looks funny, you get a CT scan, then you see the pulmonologist, they might do a bronchoscopy, then that might not get it, then you might need somebody who has to put a CT guided biopsy in it, and then after they have it finally, then you see the surgeon. So realistically, this is a process that sometimes takes 6 weeks, 8 weeks, and there's actually research out. If your time from diagnosis to treatment is shorter, you live longer. I mean, that is
sure.
Common sense, right? But it is there that the 8-week marks is a very interesting time point.
Yeah, live longer, or at the very least, live better.
Yes.
Because of that treatment taking place so quickly. What about the age limits or size of the mass, if you will, limits? Are there restrictions, or is there a threshold where someone might not qualify for treatment in the hybrid OR, where you would say, I'm sorry, I can't help you in this room, in this setting?
Yeah, I mean, it's always individualized. There is not one fits all. Sometimes we just need to do 1 or 2 of the 3, 4 different things we can do in there. It's really completely individual. It's not, there's no one size fits all, and if it's a clear-cut operation, we don't need to use that hybrid OR, we can do just a standard operation. But if we are going from undiagnosed to treatment and want to shorten the time, the hybrid OR is the one to do.
Is it better for older people because it's so, I don't want to say non-invasive, but it's minimally invasive compared to the old ways? Is it better for older folks?
I think it makes no difference.
It doesn't make a difference.
I think it's all about what's with this nodule and what we need to do with it.
You've had this thing for about 1.5 years. Is it cheaper since it's a one-stop shop and I don't have to have 10 appointments?
That's how healthcare changes.
It's not cheaper, is it?
It is probably cheaper.
Yeah.
But for the healthcare system, it's a two-sided sword right now. Right now, we get paid for how many things you do.
Got it.
We don't get paid for good care, really. I shouldn't say that, but I mean, that's the trouble. Do we get paid for because we're getting somebody a cancer treatment very quickly? Not. So I think there has to be a lot of things and change in regards how one should get reimbursed for things.
So again, you've had this thing about 18 months, the better part of 18 months. Have you had time to look at patient outcomes and what have you discovered along those lines?
Yeah, for me, that was a complete change of my life, how I approach things, because before I couldn't do it. Like very small nodules, let's say 5 millimeter, you know, 1/4 of an inch. I couldn't get to them. I had to take the whole lobe out just to do something like this. And now I can get to a diagnosis and a treatment in the same setting and do the CT biopsy myself. One can do this also as a team. I think this hybrid OR doesn't mean the thoracic surgeon has to do it all. You can do a team. You can have the pulmonologist, the radiologist with CT guided biopsies if one isn't into it, doing all the stuff to oneself. You can bring this as a team together.
Does this replace, and I think we talked about this last time, the Da Vinci system? People would know it as a robotic approach to surgery. Does this new hybrid OR and its scanning capabilities and its surgical capabilities replace that?
No. I think we're talking, these are complete different things.
Are you in the room?
Oh, sure. No, it's me. I'm there.
Yeah, you're in the room.
That's me. So this is a complete, that shouldn't be mixed. It has nothing to do with each other, and it's rather complementary rather than one or the other.
All right, but who's controlling the, and I don't know the right word for it, but the instrument that you use?
Yeah, it's me. Are we doing the bronchoscopy, the CT guidance? It's all the surgeon on the field. Yes.
How do you, okay, thanks for that clarification. How do you see the images? Is it just on a giant flat screen television? What are you looking at when you're looking at something so tiny, but thanks to this technology, it's very clear to you?
It is like you see a CT scan, you have big screens, fluoroscopy, you have, like you have it here at the media, you have several inlets and stuff, so you say 5 monitors on one big monitor, that's how it goes, and at 3 different angles in the room. So it looks pretty fancy schmancy. Fancy
schmancy makes people want to work there, doesn't it? Is this making physicians and nurses want to come to MCG?
I love it, and the nurses in the room love to be in that room too. I think it's new technology. If you're somebody who wants to do new things and is interested in the next development, I think this might be actually the next new thing in thoracic surgery. I think to shorten the interval from diagnosis to treatment will make a change in survival of lung cancer, and I think it's gonna be in the future one of the things that's just a must to have and do the treatment like that.
But I would think to have these kinds of toys would be a good recruiting tool.
Yes.
It'd be a boost for our medical community.
Yes, and the other thing, I'm doing this for 1.5 years now. I was just lately on a meeting.
Yeah.
And a lot of hospitals have a hybrid OR, but they don't know about the technology and what you can do with it. Mm-hmm. So when I got approached by Philips, then we got that OR, and they came the Philips guys, and he said, you can do this, you can do that. And I go, oh my God,
can't imagine.
I cannot. It's unbelievable what you can do with this.
It really is.
And it is just one of these things where once you realize what you can do with this, you can span out in different areas. I mean, doesn't mean it's just thoracic. Theoretically, kidney, liver, all this stuff you normally can approach with a normal CT scan option.
What about the streaming capabilities? In other words, the ability for you, while you're in that room, to communicate with other physicians, to let them real time look at what you're looking at. Is that part of the hybrid OR?
You can. I mean, that is just the next thing to do would be how do we teach it, right? And since we are a very big teaching hospital and university, that's our next thing. How can we broadcast, teach, and broaden the horizon?
Yeah, it's fascinating technology, and it really is a glimpse into the future of medicine happening right here at home, only, as Dr. Schroeder mentioned, 1.5 years into it. So let's put a face to this technology and these toys that Dr. Schroeder has been describing in our first segment by bringing in our second segment, a patient who has benefited firsthand from the hybrid OR, when the Means Report continues.